Good morning, ladies and gentlemen. We'll go on with the next session, which is biomarkers and cardiac imaging in autoimmune rheumatic diseases. We have three very interesting speakers. I'm very happy to share chairing this session with Dr. Kletas from Hippocrates Hospital.
Good morning from me as well to all.
We'll start immediately presenting the first speaker, which is Dr. Gargani. Dr. Gargani is a cardiologist and researcher from the University Hospital of Pisa in Italy, and she will present us the biomarkers and basic cardiac imaging in autoimmune rheumatic diseases. Thank you very much.
So thank you so much for the presentation. I hope you can hear me and see the slides. Okay, so this topic is really interesting because as cardiologists, we see often patients with autoimmune rheumatic disease, and we need tools to deal with these patients, which are rather different from our usual cardiac patients. And we know indeed that cardiac involvement in rheumatic disease is a very complex word because we not only have left ventricular systolic dysfunction in these patients, but we have involvement of the right ventricle. We have often a very early diastolic involvement, but we also have conduction system disease. We have all the vascular disease that will also contribute to the overall cardiac involvement, and of course the pulmonary vascular disease. And these patients also have other comorbidities which may affect the cardiovascular system. And I've put here an additional picture of the kidney because the kidney plays a very crucial role in perpetrating the cardiac involvement in these patients. And we know also that cardiac involvement is relevant in this patient. It is a main prognosticator, even in the most recent analysis of mortality. For example, in patients with systemic sclerosis, which probably are the patients among the rheumatic disease, the autoimmune rheumatic disease who have more cardiac involvement, you can see that the cardiac reasons for dying are the second after lung fibrosis. So this is something we really need to address because our patients die because of this involvement. And there are two elements which are absolutely important here. And the first one is that we need to be early. And the second one is that we need to be systematic because we have seen that it's not only a strictly cardiac involvement here, but the overall cardiovascular system needs to be addressed. And since we need to be early, we need to do something that has to be done with a kind of screening. So the screening for a primary heart involvement, here we are mentioning systemic sclerosis, but this is a kind of example for all the autoimmune rheumatic disease, should be performed in every patient. This should be done annually if you don't have a previous history of cardiac involvement. And it should be a very comprehensive assessment, including electrocardiogram, transthoracic echo, and cardiac biomarkers. So we have here already some suggestions on how to use these tools. And you can see here in the table the same suggestions. If you don't have a prior diagnosis of primary cardiac involvement in systemic sclerosis, you should have an annual lab, of course, clinical examination and TTE for these patients, whereas CMR should be considered on a case-by-case basis, and it should be also a multidisciplinary evaluation on when to ask for a CMR in patients without a known cardiac involvement. So let's see something more in details about biomarkers. For biomarkers, I will focus especially on natriuretic peptides and high-sensitive cardiac troponin. We have heard a lot in the excellent previous presentation by Professor Abate about the inflammatory biomarkers, but we have also non-inflammatory biomarkers which can be really useful. And natriuretic peptides are already in the routine clinical assessment of our patients with rheumatic disease. These are fantastic biomarkers. They are hormones actually present in the cardiomyocytes. You can find the pro-BNP in the cardiomyocytes, and then when it is released in the bloodstream, the pro-BNP is divided in an amino terminal part, which is the NT-proBNP, which is non-active part of the natriuretic peptides. And we have a BNP, which is the active part and a smaller molecule. So we can dose all the three, proBNP, NT-proBNP, and BNP, but probably the best one to be addressed and dosed is the NT-proBNP because it is more stable in the bloodstream. And these hormones are actually released in the bloodstream when we have a pressure and volume overload of our heart, especially of the left ventricle, but not only. So when you have a wall stretch due to volume or pressure overload, the proBNP is released and divided into the NT and BNP. And as you can see here, these are the European guidelines on heart failure. For us cardiologists, natriuretic peptides are a cornerstone of the evaluation of our patients in the diagnostic algorithm for heart failure. After the history and physical examination, the first examination that is advised to do is indeed dosing NT-proBNP or BNP, even before echocardiography. And we know that also in rheumatic disease, and again, we have most data, especially in systemic sclerosis patients, cardiac biomarkers such as natriuretic peptides are really important because there is a significant difference between patients with systemic sclerosis compared to controls, both in NT-proBNP and troponin levels. So even if you have the disease and also without cardiovascular risk factors and without an already known cardiac involvement, you have higher levels of both troponin and NT-proBNP compared to normal controls. And we know also that natriuretic peptides can be very useful somehow to predict the presence of pulmonary artery hypertension. You see here that it is especially specificity and positive predictive value which are high. Sensitivity is not so high, but you can see that specificity and indeed positive predictive value are really, really high. So this can be a way of doing, again, a kind of very early assessment of patients that can develop PAH or have a subclinical form of PAH. And there is also a significant correlation between the values of NT-proBNP and the values of mean pulmonary artery pressure, and also with pulmonary vascular resistance. So this correlation is solid, it is strong, and also has biological grounded. So natriuretic peptides can be somehow used as a screening tool for PAH, although, again, we should remember that they are not so sensitive. They're more specific than sensitive here. And this is also why they work better if associated to DLCO. And of course, in general, we never want to rely on just one biomarker. We must put these biomarkers in the context of the clinical patient and together with other numbers, together with other instrumental exams that we are doing in these patients. And you see here that if for PAH, natriuretic peptides are more specific than sensitive, if we go to left and right ventricular dysfunction, in this case, NT-proBNP is very sensitive, even more than specific. And again, it's better, of course, if associated to echocardiography. So here again, we have the same concept that these biomarkers works very well, but works even better if you use them in association with other tools. And you can see here that NT-proBNP has, independently of the reason why it is increased, a very strong predictive value in mortality in patients with systemic sclerosis. So whatever the reason is why they are elevated, if you have NT-proBNP higher than 125, which is a very common cutoff and not even a very high cutoff, you have an increased risk of mortality. And also troponin, and again, we are always speaking here about high sensitive troponin, can be used to predict cardiac involvement. You see here the ROC curve, sensitivity and specificity are not bad. And here, the high sensitive troponin is even more sensitive than NT-proBNP. You see here that patients with different kind of cardiac involvement, diastolic dysfunction, pericardial effusion, arrhythmias, conduction defects, all these patients had high sensitive troponin, whereas not all of them had high NT-proBNP. And again, if we go to Kaplan-Meier curves, we can see that both of these biomarkers are predictive of cardiac death. We have seen NT-proBNP, but also cardiac troponin, high sensitive troponin can be a predictive biomarker. So again, we can use natriuretic peptides as a screening test to detect patients with early cardiac involvement or pulmonary artery hypertension. And it helps to improve risk stratification and as a prognostic stratification for hard events such as cardiac mortality. But we can use these biomarkers and again also in conjunction also to try to find the good selection of patients that should undergo CMR. We have seen at the beginning that we should have an annual kind of screening with echocardiography and with biomarkers, but we cannot do an annual CMR to all our patients without known cardiac involvement. So in the last few years, we had searched for kind of red flags to identify those patients at higher risk that could benefit from an advanced imaging exam such cardiac magnetic resonance. And you can see in this study that if you have increased levels of C-reactive protein, which is another fantastic biomarker, not specific of the heart, but very useful in these patients, if you have increased levels of troponin T, and in conjunction with the presence of interstitial lung disease, which identify, of course, patients with more advanced disease, and if you have arrhythmias on your 24 hours EKG holter, these are red flags to find some kind of cardiac involvement at CMR. And similar data in this large cohort of systemic sclerosis patients is a study published last year. And again, in the search of some kind of red flags to identify patients who can benefit from a CMR, we found that a history of digital ulcer and again abnormal Holter EKG findings could predict those patients who had some late gadolinium enhancement, so signs of myocardial fibrosis somehow at CMR. And again, similar approach, if we build a score, here we call this the Sanctus score, putting together the presence of LGE and also abnormal of T2 ratio at CMR. This score was predictive of ventricular rhythm disturbances independently of left ventricular ejection fraction and baseline ventricular tachycardia. So as you can see here, there is a way to combine this assessment of biomarkers and also imaging results to better stratify the risk of our patient. On one side, to identify those patients who are going to have some fibrosis at CMR, and on the other side, to see which of these patients may be at more risk for ventricular arrhythmias, which in the end is what we want to identify in our patients because this can be linked with the serious events. So let's move on to imaging, and my task was to address the basic imaging here. And of course, the basic imaging for cardiac involvement in patients with autoimmune rheumatic disease is echocardiography. Echocardiography is the routine imaging tool to detect cardiac involvement, and in particular pulmonary hemodynamics, as we know that these patients often develop pulmonary hypertension in the course of the disease. And an echocardiography can provide us with many, many different information: left heart dimensions, right ventricular dimensions, left ventricular and right ventricular function, both systolic and diastolic, the valvular heart disease presence, hemodynamics, and pericardial effusion. But there is a first concept very important here, that even if, of course, echocardiography is a great tool and we cannot go without it, and we have to use it, again, even if you don't have a known cardiac involvement, we should not wait for a reduction of the systolic function in our patients with rheumatic disease. And this is an example of a young female with a limited form of systemic sclerosis. In 2011, when we first saw this patient, she had already an ejection fraction of 50%, which in most of the patients with cardiac disease can consider normal or to lower degree of normal. But in these patients, an ejection fraction of 50% already means an overt systolic dysfunction. And indeed, these patients had already some delayed enhancement in 2011. And 2 years later, in 2013, the delayed enhancement was absolutely increased. And also you can see here that the left ventricle is much more dilated and frankly dysfunctional here. So this is a very important concept. We cannot treat patients with autoimmune rheumatic disease with the same cutoff levels and same approach as we do, for example, in patients with ischemic heart disease. And this is true and can be testified by the fact that if we want to define systolic LV function, so presence of cardiac involvement as means of systolic LV function, the prevalence of cardiac involvement becomes very low, because it is no more than 5% in these populations, for example, with systemic sclerosis. It would increase to about 13% if instead of ejection fraction, we consider tissue Doppler imaging, which is a more sensitive tool to detect cardiac involvement. And it would even increase if we consider diastolic dysfunction. But if we do, again, a CMR, you would find almost 30% of patients without a known previous cardiac involvement with myocardial fibrosis detected by delayed enhancement. So again, everything relies on the kind of parameter you use to define cardiac involvement. And this parameter cannot be ejection fraction. Otherwise, you would have the false information that the prevalence of your LV dysfunction is very, very low in these patients. We have seen that tissue Doppler can be somehow a more sensitive tool to address the systolic function of the LV. And this is true, although there are, of course, some limitations. And you can see here that if you use tissue Doppler for both the left and the right heart, both for systolic and diastolic dysfunction, there is a significant difference between systemic sclerosis patients and controls. But there are a few things to keep in mind, that, for example, when we address diastolic dysfunction using tissue Doppler, because of course diastolic dysfunction cannot be addressed only by E/A ratio, you have also to consider age. Because, for example, when you have more than 50, 60 years, an EA less than 1, so what we call an impaired relaxation, is not necessarily pathological, especially if the patient may have a concomitant arterial hypertension. And this is also why we also need the E/A prime ratio, which is obtained adding the tissue Doppler analysis, which is very rarely more than 14 in normal subject. And we can also have a lower cutoff of 9, which would identify with more sensitivity patients with indirect sign of high left ventricular filling pressure. And there is also another, even more sensitive way to address systolic dysfunction in these patients, which is the use of speckled tracking. Speckled tracking, as you can see, again, is very high sensitive, but unfortunately, although there are tons of papers, a lot of literature about its value as an early sign of impairment, of cardiac impairment, it is not yet included in the standard evaluation. So it is done especially for research, but still you usually don't find it in your cardiac reports. And of course, patients with the same level of ejection fraction have different global longitudinal strain if they have systemic sclerosis compared to controls, but also there is a difference between limited and diffuse variant. And as you can see here, this also works for the right ventricle. You can do the strain, the speckled tracking analysis also on the right ventricle. And again, when the other usual parameters are the same between controls and systemic sclerosis, the global longitudinal strain is already capable of differentiating them. And you can apply the speckled tracking also to the left atrium. And again, you may have the same left atrium index volumes between controls and systemic sclerosis, but you already have in patients without known cardiac involvement a difference in the strain of the left atrium. Then, of course, we have the right ventricular dysfunction. This is paramount important in these patients and can be due to many different conditions. As we know, unfortunately, we have no specific therapies for this. And in echocardiography, we have seen there are some standard parameters which anyway are seldom present in our cardiac report, and rheumatologists should ask to the cardiologist to put all the parameters of right ventricular function in their report when assessing these patients. We have the fractional area change, which is a kind of ejection fraction done with the areas for the right ventricle. We have the TAPSI, which is a very simple, strong, but somehow limited parameter to assess RV function because it assesses only the longitudinal function, and you may have a dysfunctional mid and apex of the right ventricle, whereas the basal part works well and the TAPSI can be normal. Of course, we have the TDI, as we have seen before, and you may find in these very recent guidelines on echocardiography assessment of the right heart all these different parameters, and you can see how complex is the world of assessing the right ventricle in our patients. But very important, we should not forget that our patients with rheumatic heart disease may have increased prevalence of valvular heart disease compared to normal patients. For example, mitral valve prolapse is more frequent, and this is best assessed with echocardiography. Tricuspid regurgitation is very important also in patients with and without PAH, also because now we are starting to have some new devices to address the severe, massive, torrential tricuspid regurgitation that can be used also in these patients. And I would like to spend a few words on exercise stress echo. This is not necessarily a basic cardiac imaging, but you should know that you can assess your patients also during exercise. You can assess the pulmonary artery systolic pressure that you should also remember that increases with age and BMI. And this is important because the pulmonary pressure increases during exercise, and it can be due either to an increase in cardiac output, as this may happen in athletes and healthy patients, but also because the resistance increases. And this is why it can be very useful to have the ratio of the mean pulmonary artery pressure over the cardiac output, which is a way to normalize mean PAP for the increase in cardiac output. And this is included now also in the guidelines for pulmonary hypertension, although this should be an invasive assessment, which we can rarely do. And to show you a case, this is a patient with systemic sclerosis with a normal borderline function at rest. At peak stress, that for these patients was already 50 watts, we do an evaluation, which is not only of the left ventricle, but we also evaluate the pulmonary pressure, which increases during stress, and we evaluate the cardiac output. And you can see here that the ratio is more than 3. So actually there is a disproportionate increase in pulmonary artery systolic pressure compared to the increase in cardiac output. And we still don't clearly know what to do with this number, but this is somehow indicating that this is already a kind of dysregulation of the pulmonary circulation. And if we see the slopes of the mPAP over cardiac output in different populations, you can see here the violet are the patients with connective tissue disease, that the curve is much steeper than controls, athletes, and patients just without cardiovascular risk factors. And there is also a prognostic value of this slope and also of the TAPSI over SPAP, which is another very simple but powerful predictors in these patients. But what the standard echo cannot tell us is about tissue characterization. I will go very quick here because I think that the next presentation will address cardiac magnetic resonance very deeply. So if you want to see edema and fibrosis, you cannot rely on an echocardiography. And this is very important because myocardial fibrosis, we know now very well that is often present without symptom, without increased cardiac biomarkers, and often with a normal LV systolic and diastolic function at echocardiography. And you can see here that CMR among cardiac imaging is the strongest one that can address almost all the different involvement in our patients. But remember that for pulmonary hypertension and for valvular heart disease, echocardiography is still superior to CMR. And I would like to close with this clinical case. This was, again, a very young woman with systemic sclerosis, a limited cutaneous form diagnosed many years ago in 2008. At that time, she had everything normal for cardiac involvement. But a few years later, she developed digital ulcers. So in 2019, the only new clinical thing is the development of digital ulcers. The echocardiogram is apparently absolutely normal, not only the ejection fraction, but also the diastolic function, left atrium volume index, the pulmonary pressure, NT-proBNP, everything is absolutely normal. She was mostly asymptomatic, but she had sometimes palpitation. And indeed, the Holter EKG had a few extrasystolic ventricular beats. So the CMR of these patients that was done because she had these red flags of both digital ulcers and alterations on the Holter EKG showed normal dimensions and function. There was a small LG area, but she had a frankly abnormal T1 mapping. So again, this was a patient with a completely normal standard echo with a slightly abnormal standard CMR, but we have seen that we find this in many patients, but with a frankly abnormal advanced CMR. And I'm not happy to show this because I would like to have parameters on echocardiography to predict the presence of cardiac involvement. But this is to say that unfortunately, the cardiac involvement in rheumatic disease, especially in systemic sclerosis, can be very, very subclinical and sometimes even advanced techniques such as CMR, if you don't do all the parameters, may seem normal or with just small alterations. So this brings us to the take-home messages, which is that cardiac involvement is frequent in autoimmune rheumatic disease and often subclinical. And in the beginning, it is always subclinical. Cardiac biomarkers can help in screening for both cardiac involvement and PAH, and they are very strong as prognostic stratificators. Echocardiography, of course, is the current routine imaging tool to assess cardiac involvement in systemic sclerosis, but in all autoimmune rheumatic disease, can assess LV and RV dimensions, systolic function, hemodynamics, and valvular heart disease, but it can detect only overt cardiac involvement, and we unfortunately cannot wait for this overt cardiac involvement. So we need CMR to be much earlier, although of course echocardiography remains a cornerstone of the evaluation, as we have seen, especially for the pulmonary hemodynamics and valvular heart disease. So we have unfortunately this kind of relentless silent burning, which is a cardiac involvement in our patients, and this is why we have to be well aware and very early to address these patients. Thank you.
Congratulations, Dr. Gargani, for the excellent talk and very, very comprehensive talk. We have some comments from Dr. Mavrogianni first, and then from Dr. Kletas.
Thank you very much, dear Luna. It was an excellent presentation, very well balanced, presenting the role of each parameter, and we really enjoy your talk. I'd just like to add that using the current anti-rheumatic medication, we have a drop in the percentage of pulmonary hypertension and systemic sclerosis. In the past, it was 15%, 15 to 20%. Currently, it's 2 to 7%. However, at the same time, we have an increase in arrhythmias just because these patients live more, and we have to be aware of this, and CMR can be of great value, as you emphasized already. And for this reason, we have to keep it in mind. The other thing is that the strain parameters measured by echo are following the pathologic increase of T1 mapping. There is only one study proving that in systemic sclerosis. So we have to keep this in mind. Of course, it's an early index, but it's an early systolic index, not an early tissue characterization index. So this further emphasizes the role of parametric CMR imaging. Thanks a lot for your contribution, generally in the field, and more specifically in this meeting. I'm really grateful, Luna. Thanks.
Thank you so much, Professor Mavrogianni. Dear Sophia, I cannot add anything to what you have perfectly summarized, a lot of main points. And I do agree that strain analysis is very nice, especially for research. But if after more than 10 years that we have seen these papers, it is not included in the routine clinical use in these patients, probably it is because it's a way to characterize the pathophysiological continuum of the patients, but maybe it is better to use CMR for the early stratification.
Okay.
Okay. Dr. Kletas, yes, please.
Yes, thank you. Good morning, Dr. Gargani. Thank you very much for your talk. Yes, indeed, it was very interesting, and you concentrated a lot of things in the talk. Thank you very much for this. I would like to ask you a question that given that the fundamental principle is that the diastolic function is the one that probably get problematic before the systolic function, and you showed some images about stress echo that you normally assess pulmonary pressures and systolic function. So what about stress echo for diastolic function to these patients that they don't have any profound or any remarkable diastolic dysfunction in the resting echo? And maybe we can reveal cases that they have developing diastolic function as an early stage problem.
Yeah, thank you very much for this question. This is absolutely relevant because when we address diastolic dysfunction of the left ventricle during exercise, this can also be a way to better understand the etiology of the increase in pulmonary pressure. Because, of course, these patients may have an increase in pulmonary pressure, not only due to the increased vascular resistance, but also due to the increased left ventricular filling pressure. And a diastolic dysfunction during exercise could somehow display this situation. The problem is that the assessment of diastolic function during exercise is not so easy because especially EON-A tends to fuse with high cardiac frequencies. And so it has been done, there are papers on that, but again, it's not routinely used to assess these patients, and somehow it is easier to assess the pulmonary pressure during exercise than the left ventricular diastolic function. But I agree that if you want to do a comprehensive assessment in these patients, both parts should be evaluated, and somehow you can balance the different components of pulmonary hypertension development in these patients. What we have found in our population is that, again, we have a very high negative predictive value of these parameters. So if you have a patient, so you put it on a bicycle and the pulmonary pressure is not significantly increased, in the next many years that patient is not going to develop pulmonary hypertension. On the contrary, because of what you have underlined, that we also may have diastolic dysfunction on exercise to be a component of pH. If you have an increased pH during exercise, you need to understand what is the mechanisms, and it is not necessarily linked only to the vascular involvement.
Mm-hmm. Okay, thank you very much. And okay, so let's move further, because I understand